Two riddles, one ancient and one new. There is a house. One enters it blind and comes out seeing. What is it? A school. There is a device. It knows you're breathing better than you do. Garbage to the body, treasure to trees, gold to MDs. What is it? EtCO2. The first riddle is 4,000 years old, written in cuneiform, originating in the ancient kingdom of Sumer, the same place where we have the first examples of writing. The second one is, well, I just came up with it. Bear with me. The critically ill child, or the one who gets into physiologic trouble during sedation, may at first pose a riddle. What is happening? Is he breathing? What is his physiology at this moment? EtCO2 monitors have been around for a while, but do we really feel comfortable about all the ins and outs? When do I rely on a quantitative level, and how exactly do I interpret that qualitative waveform? All of these questions to be answered coming up next.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
I want you to think of yourself as a resuscitation ninja. You know the lay of the land before the patient even knows you're there. EtCO2 is a way to quickly get a snapshot of what's happening right now, a physiologic, immediate, situational awareness. Before we start your training in the martial art of exhalation, let's flesh out exactly what we're talking about. What is EtCO2? It's all about respiration in 3 parts. It starts at the level of the cell. Normal cellular processes consume O2 and produce CO2. So far, so good. Then, there is the transport of this produced CO2 from the capillary beds to the pulmonary circuit, where both O2 and CO2 diffuse across the alveolar membrane. Finally, we have ventilation between the alveoli and the ambient air. So, the 3 parts are production, transport, and ventilation. We can use clues in the history and physical to pinpoint where is that problem along the production line. Let's talk about how the EtCO2 detector works. The answer is infrared. CO2 detectors operate on infrared technology. The CO2 molecule, because of its structure, will absorb only specific wavelengths of infrared light. So you have the CO2 detector placed under the nose, maybe in a nasal cannula setup, or entrained into your bag valve mask device, or the ventilator, or even an oxygen mask. The CO2 enters into the device chamber, and the infrared light beam passes through the exhaled gas. There's a sensor on the other side that detects the remaining infrared signal that makes it across the chamber. It's like a headlight beam in a fog. The murkier it is, the less light passes through to the detector, in this case, your eyes. So the sensor's computer subtracts the signal generated from the signal that's detected. This is how we can monitor the breath-to-breath level of expired CO2. EtCO2 rises and declines reliably in certain disease states. And depending on the clinical context, we can surmise where along the production chain the problem is: the cell, the circulation, or the lungs. First, let's talk about what would show up as an increase in your end-tidal CO2 number. On the cellular level, any muscular activity, so seizures or spasms, as well as malignant hyperthermia. On the circulatory or transport level, you may see an increase in end-tidal CO2 because of improved resuscitation or even tourniquet release. We often see end-tidal CO2 levels rise in the pre-hospital setting when high-quality CPR is performed, and it may even help direct our efforts. At the ventilation level, end-tidal CO2 rises with bronchorelaxation. The asthmatic who is responding to treatment. This is partially why you'll see a VQ mismatch in asthmatics. The SpO2 will decline first and then rise with therapy. It's that VQ mismatch that is making its way back to equilibrium. Also, any disease process that causes a decreased minute volume will increase your end-tidal CO2. So, post-seizure hypopnea or opioid overdose, or, there's just so many more that we can think of. Those are all examples of how end-tidal CO2 will increase in certain conditions. So, what will cause a decrease in your levels? From a cellular or production level, hypothermia is the classic example. Even though the respirations may be normal, you'll see a depressed end-tidal CO2 reading because, the body is just not metabolizing at the normal rate. On a circulatory or transport level, low cardiac output, for example, will cause a decrease in end-tidal CO2. So shock states, or even a left ventricular outflow obstruction, such as in critical coarctation or symptomatic hypertrophic obstructive cardiomyopathy. Another classic example is pulmonary embolism, causing obstructive shock. On the pulmonary or ventilation level, bronchospasm. This will cause a decrease in end-tidal CO2 levels. Do you remember that asthmatic that you saw the other day who was working hard to breathe? If you were to put an end-tidal CO2 monitor on him, you would have recorded a level of perhaps 20 or 25 millimeters of mercury. So that's an example of not getting the CO2 out of the pulmonary circuit, of poor ventilation. But anything causing an increase in minute volume, so even hyperventilation, for example, will detect a relatively lower breath-to-breath end-tidal CO2 level. DKA, for example, or just plain anxiety. Let's talk now about the most accessible use of end-tidal CO2, the most visually satisfying, the qualitative analysis. So just looking at the waveform itself can be like peeking into the window of the child's physiology. As you'll remember, the uptick in the wave is exhalation that rises, then plateaus in a gentle upslope before it plummets down as the child takes a breath. The waveform is measuring CO2. That moment, just before the plummet, the cliff's edge, that's the maximum level of CO2 in exhalation for that breath, otherwise known as the end-tidal CO2. That's where we generate the actual number. Most commonly, we'll place a nasal cannula that supplies both oxygen and reads CO2 by way of a small reservoir. Some names you may see are capnoline or microstream. Anyway, you place this on someone who is getting sedation with an agent that places them at risk for hypopnea. So say propofol, where we have the most evidence basis for using this, but I'm sure you've seen it done before with our favorite drug in the whole wide world, ketamine. So the child goes from awake and alert to sedated, and you see a nice uptick in the waveform as she breathes out ending in a gentle plateau, then a sharp decrease with inspiration. Now, of course, any physiologic monitoring is only supplementary. We really should be using our eyes and ears and hands to see and feel for the chest rise, to monitor the pulse, to look for the respirations and the skin color, listen for any stridor or sturder. Okay, but anyway, you're monitoring this child undergoing a procedure to your heart's content. You see a normal breath out, and then some small squiggles, and then some more little squiggles. And if this were an EKG, you would swear this is an irregular rhythm. And you're just about to check the equipment when you see a large deflection, larger than any of the previous end-tidal CO2 waveforms, and then back to a normal pattern. What was that? And what did you do wrong? First, you didn't do anything wrong. I just wanted to sweat you there for a second. It's at that moment when you're doubting yourself. You see these little squiggles that shouldn't be, or you have that little twinge of what is going on. It's at that moment that your first instinct should be to look at the patient. Feel for the chest to rise. If you had done that, you would have seen that he was, in fact, hypoventilating and in an irregular pattern, and that's why you have those little irregular, small, shallow squiggles. Then he took a compensatory deep breath. Now, this is why being a resuscitation ninja is so important. It's not just paying attention to what's going on, but knowing what to do about it. This may have been your only warning that this child may be too deeply sedated. His level of consciousness is drifting from what you want, sedation, to what you're looking out for, general anesthesia. When you see normal end-tidal CO2 waveforms, and then small, shallow breaths, and then a large compensatory waveform, you're in too deep. Stimulate the patient or lighten the sedation. All right, new scenario. You are working on a sedation for someone with a traumatic injury, for example. You see slow, long waves of exhalation. All of them register above your reference point of, say, 40 millimeters of mercury. So the number seems all right. And remember that our normal end-tidal CO2 should be between 35 to 45 millimeters of mercury. So we'll just use 40 as a reference point. So the number is okay, but you see this slow, long waveform. It looks like your normal waveform has just been stretched out. You go from this normal box waveform to a long rectangular waveform, and you may think, cool, the waveform is full and at or above the reference range, 40 millimeters of mercury. So every individual breath will register at the normal, but his respiratory rate is so slow, like 8 breaths per minute. This may not jump out at you, but this is bradypneic hypoventilation. Although the quantitative end-tidal CO2 looks good, qualitatively, we can see that if we don't do something about this soon, he's going to incrementally retain small numbers of CO2 and become apneic. Also, with that slow of a respiratory rate, the oxygen tension in the blood starts to creep down. We see bradypneic hypoventilation classically an opioid overdose. So, bulky waves that are too slow, bradypneic hypoventilation. Okay, we just gave them too much. We'll reposition, provide supplemental O2, stimulate, and watch the narcs. There is another type of hypoventilation that we should talk about when we're doing a qualitative assessment of end-tidal CO2 waveforms. Hypopneic hypoventilation is when your normal box-like waveforms turn into smaller cubes. That is, when you have a normal exhalation, but then you have much smaller waveforms in comparison. They may be at a faster rate. They're fast, but they're inadequate breaths, usually half of the amplitude you're looking for. So they look like they're about the right morphology, but they're smaller and they'll dip under your normal threshold of 40 millimeters of mercury. Small, faster, inadequate breaths result in hypopneic hypoventilation. This is seen in sedative overdosing, especially with benzodiazepines or a hypnotic agent like etomidate. Small, fast cube waveforms, think hypopneic hypoventilation. You are just not taking deep enough breaths. Although your respiratory rate is normal, or it's even faster, you're just not ventilating enough and are also at risk for retaining CO2, becoming hypercarbic and apneic. Stimulate, reposition, and hold the sedatives. Those are two examples of inadequate ventilation in two different morphologies. But what about the early detection of airway obstruction and apnea? You may see a normal box waveform. Everything is going great. And then out of nowhere, you see irregular waves that are small. There's really no symmetry. There's no pattern between the waves. That is airway obstruction. Now, this is at the point where it might not be so obvious clinically. All it takes for the hypopharynx to lose tone is just a little extra sedation, and that results itself in worsening ventilation, as we can see with the breath-to-breath variability in end-tidal CO2. If you're lucky enough to hear any upper airway sounds when someone is obstructed, it's really late in the course of their obstruction. That's just the brain's attempt to create negative pressure to pull in oxygen. Because, as we've been saying, oxygenation and ventilation do not necessarily go hand in hand. We can deal with some ventilatory issues for a while. We can tolerate a little extra CO2, but we are not very good at tolerating low levels of O2. If you hear airway obstruction sounds, that's a last-ditch effort for your body to oxygenate. We're not even talking about ventilation anymore. So if you see an irregular tracing that follows no pattern, this is obstruction. An obstruction waveform on end-tidal CO2 looks like, let's just call it ventilatory AFib, irregular. Do not wait for total apnea. And don't wait for your SpO2 monitor to show anything. We're not waiting for this person to desaturate. You don't want to wait for there to be an obvious clinical finding. You want to catch it at the moment using end-tidal CO2 detection. So if you see the beginning of obstruction, don't assume it's an artifact. Lay your hands on the patient. Do you feel the chest rising? Maybe not. If you have any issue, any concern, any doubt, put the child into a sniffing position, put a roll of towels or a blanket under the scapula, and open that airway. Okay, here's a vignette for you. You see close to nothing on the monitor. Do you A, check the cannula, B, put your hand on the patient's chest, C, check the pulse oximetry reading, or B, YOLO? The answer is B. Check the patient. Always check the patient. What is his skin color? Put your hand on the chest. Do you feel excursion? You can always do these other things, but remember that technology is your friend, not your master. Always use your low-tech senses first. They will not fail you. Okay, you see a little squiggly on the capnographer, and maybe you feel like if this were an EKG, it looks like, I don't know, fine VFib or asystole. That's bad. No breathing. But we can fix this. We have the technology. Open the airway. Did that fix it immediately? No, this child needs rescue breaths. Just go for it. If it ends up being a matter of oversedation, the positive pressure ventilation will stimulate him to breathe and fuss. If not, then bonus, you're already fixing that problem. Start troubleshooting, and if this is an opioid overdose, you can consider Narcan and small aliquots, or you can just bag him through it if it's something like propofol or a fast-acting sedative like that. If you're using ketamine, this may represent laryngospasm. Remember, slow, constant, positive pressure ventilation will break that spasm. The force of air will overpower the arytenoids, but sometimes you have to use the pop-off valve and cover it up to get a little extra pressure. Get to work. Your patient needs you. And by the way, bonus points for catching it at the moment it happened through capnography and not because you lost a pulse. Okay, maybe you lost a pulse. It happens. You have to intubate. Or maybe the patient is already intubated. Let's go quickly over a few of the waveforms you'll see when the patient is placed on the ventilator, and then what to do about them. Let's start with immediately on intubation. Of course, we identify placement by seeing the tube go through the cords, ventilating, seeing the colorimetric change to that happy yellow, the chest rise, the child's doing well. But maybe on transport up to the unit or to the CT or to another gurney, or even smaller children, it can just become dislodged. You may see normal boxes followed by a little blip, then what looks like a slow rumble, very similar to the apnea waveform. Because, well, as far as the machine is concerned, there is no respiratory effort detected because the tube, my friend, is now in the goose. Yes, end-tidal CO2 may be your first look at an esophageal intubation, especially in the previously intubated child who gets jostled or moved. Pull that tube. Do it. Just do it. Place a supraglottic device in the meantime, or just do bag valve mask ventilation. You can always attempt endotracheal intubation in a moment, but the critical action here is to make the decision to pull that tube. It's not doing anyone any favors, and you are not going to be able to salvage it. Just pull it. All right, now it's getting interesting. What if you see nice boxes in a row? Nice, even, symmetrical, normal-looking waveforms, except for, why is there a notch on the upslope? It looks like a little dent in the gentle upsloping plateau. The patient seems okay for now, but you're pretty astute. You realize this isn't normal. When you see a bifid waveform, that is, a notched upslope, you have on your hands a right mainstem intubation. This is so easy to do in pediatrics. In adults, we have more real estate to work with, and if you happen to be a little overeager in your tube placement, it's probably still okay. You just end up losing style points. In children, we place the endotracheal tube with the cuff just past the vocal cords, and that's it. But I've done this so many times I can't count. Let's just say if I'm a little extra enthusiastic, the tube ends up being so low it needs repositioning. Right? You see that main stem intubation without even trying. Now, you may not see a large dip in O2 saturation. You may see a very normal-looking capnoform except for that notched or bifid waveform. That notch represents the fact that the CO2 ventilated from the right lung is very quick to get into that endotracheal tube. It's immediate. The ventilation from the left lung is delayed, and it diffuses over, causing a mini plateau within that plateau, so a notched appearance in the capnographic waveform. Now, of course, always check the patient first, and you'll likely hear asymmetry on breath sounds. check the tube insertion. Remember, it's 3 times the endotracheal tube size for depth. And finally, you can use ultrasound or chest x-ray if you're unsure. In the more critical cases, just do direct laryngoscopy again and visualize a tube, deflate the cuff, pull back slightly, then reinflate. It helps if you have someone helping you to deflate, to listen, and decide. Just remember, notched plateau, that is a right mainstem intubation. You see a teenager who got behind in his bronchodilators. You throw everything at him. He tires out. You've done everything you can not to intubate this asthmatic, but you're forced. Or maybe you have a child in extremis from severe viral pneumonia. She needs endotracheal intubation. But in any case of a patient who may have bronchospasm after intubation, watch for that sawtooth pattern on your capnography waveform. It looks like a coved sawtooth rising reluctantly in a curve to the point of exhalation. It's characterized by that curving upward. Basically, the whole exhalation phase is a curved, forced shape, never quite getting to a plateau. It's hard to get that air out, and then it plummets with inspiration. Almost a straight drop down, resembling a sawtooth. The dead space has not finished emptying, and you have that plateau that's interrupted. Remember, sawtooth equals bronchoconstriction. So, give more bronchodilators and suction as needed. Maybe your bronchoconstriction worsens. Or now there's a large wad of mucus obstructing the airways. You initially might have had, with bronchoconstriction, a little sawtooth pattern that shows difficulty in ventilation, but now you're obstructed and that sawtooth is compressed. It's smashed down to create a more narrow shark fin appearance. This is obstruction. So the problem with this now is that before, when you had only bronchoconstriction, ventilation was the problem. You had this sawtooth pattern. Ventilation is mostly the issue. With the shark fin, the compressed version, you have problems now both with ventilation and oxygenation. Your I-to-E ratio is worsening. Now remember, with a curved upstroke in ventilation, you see a slow downslope in inhalation. Shark fin. That shows an airway obstruction. Suction, reposition, continue bronchodilators, and batten down the hatches and figure out what is obstructing this child before it's too late. Next patient. You've just intubated a child for pneumonia, or maybe that was severe bronchiolitis. Initially, she's doing well. Then, maybe you see some tachycardia, or an unexpected anion gap, or something a little more subtle. The transport team won't be here for a while. Or maybe your PICU is full. Or you're just managing the first few minutes or hours of this child's critical illness. You see a normal upstroke on the end-tidal CO2 capnography. Patient's ventilating okay, it seems, but the pattern of the plateau is the opposite of normal. Instead of a gentle upslope, you see this gentle downslope. What's happening? With critical parenchymal disease, the alveolar slope is reversed. The gas exchange surface area is so poor and the compliance of the lungs is so abnormally increased that the alveolar gas exchanges very rapidly where it does occur. And here you see this early peak corresponding better to the arterial CO2. So gas in the ventilator tubing backwashes to the patient. An abnormally high CO2 equilibrium is then achieved in the circuit. So what do? You monitor and you optimize those settings. Expect this to get worse before it gets better, but do what you can to support all else while that parenchyma is healing. Next patient. You've intubated. The waveforms look pretty normal. Exhalation causes that uptick, and inhalation causes the downtick. Breathing nicely on the ventilator, when you start to notice that the uptick is normal, the gentle upsloping alveolar plateau is fine, but the end tidal point, just before dropping, you see a little uptick, like someone even pinched the end tidal point into a sharp little end. Or if the body of the waveform is the rump, then that sharp uptick is the little pigtail. We see the pigtail waveform in a poorly compliant lung. There's that last gasp, a sudden peak of expired CO2 just before sudden airway closure. When a poorly compliant lung or obese habitus, also this can happen in pregnancy, this makes the last few alveoli collapse under the weight, and there's that sudden peak of expired gas. If you see this in a patient who's not doing well, you see that little pigtail, that little sort of pinched off, squeezed end tidal point, consider side positioning or prone positioning as needed for optimal gas exchange. And finally, when you see low volume waveforms, it has a normal morphology, but they look like our familiar little boxes, just low values. Think of low CO2 production. It looks normal, it's just not rising to the normal quantitative level. If this were someone spontaneously breathing, you might think that this was hypoventilation, maybe due to some oversedation or over-narcotization. But this child is intubated. We are doing the ventilation for him. With proper tidal volume and good chest rise, you will still see low volume waveforms because of low CO2 production from a number of pathologic conditions like low flow states, for example, shock, or for example, in hypothermia, when the total body CO2 production is decreased by 6% for every degree below 36 degrees Celsius. So just remember, if you have a ventilated patient with low volumes in your end tidal CO2, think shock first or some other metabolic problem that's causing a low production of end tidal CO2. This may be your first look at the body's metabolism starting to maladapt. Okay, we've used our visual cortex far enough. No more visualizing what I'm trying to say. Let's talk black and white facts. The waveforms are important to qualify what's happening breath to breath, but sometimes we need a more objective number to make decisions. Let's talk quantitative end tidal CO2. Remember that normal end tidal CO2 ranges from 35 to 45 millimeters of mercury. So again, if you have to remember a number, remember 40 millimeters of mercury. Normally, end tidal CO2 is up to 5 millimeters of mercury lower than the measured PaCO2. End tidal CO2 is slightly lower than the ABG PaCO2 because we're measuring the exhale version and some of the alveolar dead space is always present. But truthfully, for our intents and purposes, let's just say that end tidal CO2 is really the PaCO2. Okay, you have a child who seems sick. Let's say a 2-year-old who is listless. You hook her up to the nasal cannula that has both end tidal CO2 and oxygen. Her end tidal CO2 quantitative measurement is increased. Let's say it's at 50 millimeters of mercury. From a cellular metabolic level, this may be due to her fever. Or on a cardiovascular level, this may be her increased systemic vascular resistance from her compensated shock, maybe sepsis. If we leave her there, she may become obtunded and hypoventilate, further increasing her end tidal CO2. Okay, do you have that image of her in your mind? Think lethargic, a truly lethargic toddler with fever. The end tidal CO2 is high. If you weren't worried before, you should really worry now that we have an objective number. Now, obviously, you won't use end tidal CO2 to make that diagnosis, but I'm sure you can see different variations on a theme where the obvious physical findings are not really that dramatic, but you're worried enough about this child to place the end tidal CO2 monitor, and those clues show you that this may be early septic shock. On the flip side, if you have a kindergartner who was in maybe a multi-vehicle collision, it was the first rains of the season and the oil slick on the road caused that pileup and your patient arrives. He's wet. He has a femur fracture. If you were to place a nasal cannula on him and read his end tidal CO2, it would read, say, 25 millimeters of mercury, so low. On the cellular level, his hypothermia may be causing decreased production of CO2. From the cardiovascular transport level, his hypotension or hypovolemia from the trauma may be causing a decrease in transport of CO2, causing a decreased measured quantitative reading. Also, from the pain and anxiety of the accident and situation itself, he is hyperventilating. The quantitative reading per breath is low. All right, you knew all of that. Let's talk about specific cases where the quantitative end tidal CO2 may help you to make a decision in patient care and not just, that's cool to know. Gromets et al. In 2010 found that in cardiac arrest, an abrupt rise in end tidal CO2 of greater than or equal to 10 millimeters of mercury during resuscitation was a favorable sign that return of spontaneous circulation may be imminent. Mark Eckstein et al. In 2011, on the flip side, found that a persistently low end tidal CO2, so persistently less than 10 millimeters of mercury after 20 minutes of resuscitative efforts, that predicted death. It may be helpful to know in cases where emotions are high, you've worked really hard on this child, but in your heart you know that you finished. You can point to a number. After 20 minutes of resuscitative efforts, if a persistently low end tidal CO2 of 10 or less, this child is not going to make it. Now, we make clinical decisions based on the whole context, of course. Hypothermia? Then this doesn't apply. Drug overdose? Reconsider. Use quantitative end tidal CO2 with caution in being your only thing to make your decision. But it is helpful to know, especially if you're trying to give some advice in the pre-hospital setting with online medical direction, that after 20 minutes of CPR, if your end tidal CO2 is consistently less than 10 millimeters of mercury, this is very strongly associated with no return of spontaneous circulation. Conversely, just to try to be a little more hopeful here, if there is a persistent reading of 20 millimeters of mercury or more, or if there's an abrupt rise in end tidal CO2 of 10 or more, then this correlates with return of spontaneous circulation. Now, with anything, there are caveats. Our friend Cliff Reed et al. In 2015 did an amazing study where he measured the end tidal CO2 readings in cadavers. Yep, the person may be dead, but the flesh is still alive and the cells just haven't gotten the memo yet. These cadavers were frozen for 5 days after death. They were thawed 4 days out prior to the study, and Cliff and his team ventilated them and measured their end tidal CO2. What did he find? After 100 seconds of ventilation, they got readings on average of 65 millimeters of mercury. At 50 seconds, 45 millimeters of mercury. It's a little mind-blowing, but it also highlights the importance of applying the right test to the right person. So use it all with caution, but it may support your decision and what you know in your clinical heart of hearts of the right thing to do. A more common clinical scenario is the child at risk for severe sepsis. In 2009, McGillicuddy et al. Found that an end-tidal CO2 of less than 35 millimeters of mercury correlated strongly with an increased lactate level and an increase in SOFA scores. The SOFA is the Sequential Organ Failure Assessment Score, and it's a composite score that predicts mortality on admission and in 24-hour increments. It's really a research tool, but it's also a proxy for how sick the patient is. So, low end-tidal CO2 in sepsis is bad. Either the cellular production is stymied, or the cardiovascular transport is terrible, or there is some combination of both and ventilation. Hunter et al. Later showed that low end-tidal CO2 predicted mortality in sepsis patients. In short, end-tidal CO2 may be an early sign of acidosis and poor prognosis in sepsis before you even get your laboratory results. Look for an end-tidal CO2 of less than 35 millimeters of mercury and consider early aggressive resuscitation. Another common scenario where end-tidal CO2 may be helpful is in trauma. In 2017, Stone et al. Found that end-tidal CO2 of less than 35 millimeters of mercury was associated with the need for more blood products and was correlated with increased mortality. Now, in a busy ED, in a distracted ED, labs may take some time, or it may take some time for you to actually get that result, to look for it. Consider early end-tidal CO2 in severely traumatized patients to predict blood product administration or the need for it to anticipate. Also for ventilatory status in blunt head trauma patients. The data on cardiac arrest, sepsis, and trauma, they're not perfect, but they're probably the best we have when it comes to clinical decision-making with quantitative end-tidal CO2. The next few presentations we'll mention have less robust evidence behind them, but they're good to know about, to be aware of if they come up at the bedside, or if someone really wants to put some credence into them, they're not really ready for prime time. In 2016, Gilhotra et al. Looked into whether end-tidal CO2 was helpful in predicting DKA in patients arriving to the ED with hyperglycemia. Now, this would be great, right? It would be so nice if the child with hyperglycemia comes to the ED and we can quickly detect the presence of diabetic ketoacidosis early on by non-invasive measures, or even used in triage. But the numbers they used just did not pan out, and it's just not ready for prime time. Besides, someone who looks that sick, you're going to know what to do and you're going to bring them back. Anyway, we know that children with DKA can have pretty much any CO2 that they want to have. If it's low, it's probably terrible that he's hyperventilating, trying to blow off his acidemia with a respiratory compensation. However, as that child becomes more and more tired or sicker and sicker, he's unable to compensate. His PCO2 rises, making him now a much more critical patient. So, in well-appearing children with hyperglycemia, knock your socks off, put on the end-tidal CO2. If they look sick, don't wait for the end-tidal CO2. Now, end-tidal CO2 has also been studied for children coming to the ED with presumed gastroenteritis. We're trying to figure out, do we need labs? What is the bicarb on this child? There was a weak correlation with end-tidal CO2 and serum bicarbonate levels in this study. There's just too many factors at play to make this predictable in any way. So I say just junk it. Okay, are you with me? That was a lot, but I know you got this. In summary, qualitative waveforms give you a breath-to-breath look at the physiology of your patient right now. Quantitative numbers may be helpful to make some tough clinical decisions, an extra objective finding if used in the right clinical context. When troubleshooting, always look at the patient first. Use your eyes, your ears, your hands to assess. Try to figure out, is this increase or decrease in end-tidal CO2 due to a problem with production at the cellular level, with transport at the cardiovascular level, or with ventilation at the pulmonary level? Don't let disease creep up on you. Be the ninja you know yourself to be. find the decompensation before it finds you. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.